Advocacy Incubator's unofficial virtual WHA side event. My name is Claire Wingfield. I am the Director of Advocacy in the Food Policy Program at the Incubator, and I'll be your moderator today. This webinar is being recorded. We are also offering Spanish translation, so please click the interpretation button at the bottom of your screen and select Spanish for simultaneous translation. We're here today to discuss why advocacy for public health is more important than ever as COVID exposes gaps in our health systems and threatens past gains we've made. We have an impressive panel of advocates here to talk about their work and how they're pushing to continue to advocate for public health in the current environment when lockdowns, strained budgets, and politics make it harder to keep and get policymakers' attention. Before we start, I do want to acknowledge the difficult situation with COVID-19, particularly in India and Brazil. And I want to thank our colleagues for making the time for joining us today for this important discussion. It is my pleasure to introduce Dr. Arit Kaur. She is the director of the National Health Mission in the state of Punjab. She's here to discuss the impact of public health policy and advocacy. Dr. Kaur is responsible for policymaking, planning, and implementation in the state of Punjab. Her primary areas of focus are public health system strengthening, epidemic preparedness and emergency response, including COVID-19, ophthalmological services, maternal health, tobacco control, and NCD control. Dr. Kaur, thank you very much for joining us. Can I ask you to turn on your screen? Thank you.
Hello, yeah. So I will start with my experience that how we started in 2019. We started developing our public health system around units called health wellness centers. And these health wellness centers were located in rural areas of Punjab. We were looking at 10.7 million rural population of our state. And we created these units which were looking after 5,000 population. So in 2019, when we started, we were looking at screening our people for non-communicable diseases like hypertension, diabetes, and cancers, and providing diagnostics and continuum of care to these persons. Also, we were looking at screening TB patients, screening antenatal women and all. But and we were kind of first in this country in operationalizing health wellness center, in the sense that we almost covered 75% of our population in the first year of launch of our program. But then in March 20, when the COVID stuck and there was a very strict lockdown all over the country and in the state, there was a clampdown on travel, there was no public transport. So in rural areas, our health wellness centers became a unit which kept a connect between the medical services and people. People could come in the village level to the health wellness center for checkups, for diagnostics, and for medicines. Also, the medicines were provided at home to the people by the health wellness center team. By the way, this health wellness center team comprises of a community health officer with 2 multi-purpose workers and 5 village level volunteers. So we were able to continue. Later, when the lockdown was lifted, but the pandemic was still there, we did capacity building of our community health officers. They became trained for sampling, for vaccination, for care of COVID positive patients in home isolation and giving them counseling, etc. Also at that time, in March 20 itself, when the pandemic started in India, we established a telemedicine hub. So the community health officer could do video calling of the patient with the specialist at the hub, and the doctors at the hub could give consultation to the patient in rural areas through the community health officers. Also, throughout this period, we strengthened our system by providing drug delivery system. We have taken up vehicles which provide medicines to the health wellness centers. And health wellness centers have become a hub of activity for all the rural population of our state. Here I would say the pandemic has rather uh, made our public health system strengthen. It has strengthened it as never before, because it has been proved that only public health system can deal with the crisis like pandemic, like COVID-19. And public health system is the answer to you see the problems our people face. Here also I would thank agencies like Global Health Advocacy Incubator, because when we wanted to establish our telemedicine hub during pandemic period, they helped us with the internet services, and they have been kind of an ombudsman for our whatever the project, and we very much welcome their suggestions, and whatever directions they sometimes give us, the suggestions they make. So thank you so much. That's all.
Thank you so much, Dr. Kaur. I do have a number of questions, but I will wait till the Q&A session. And I want to encourage our participants to also turn on, to actually use the Q&A box to ask any questions for our panelists. And then also you can use the chat to share any of your own experiences, any thoughts that you would like to we'd like to create a space for everyone to share their thoughts and experiences. So I will now turn to Paula Johns in Brazil and Nalin Sinha in India to discuss protecting health gains in a world transformed by COVID. Paula is the co-founder and director of Acetate Tobacco Control Alliance, a Brazilian coalition of over 1,000 members. Paula and Acetate advocate for policies for tobacco control, as well as other non-communicable diseases and civil society mobilization, both nationally and internationally. She is also a former chair of the board of directors of the Framework Convention Alliance and a member of the Brazilian National Health Coalition. Nalin Sinha is the in-country coordinator for Global Health Advocacy Incubator's road safety program in India. And in that role, Nalin is instrumental in advancing the advocacy work of the Road Safety Coalition in India. Paula, I'd like to start with you. And because of COVID-19, everyone is thinking about public health systems and why it's necessary to protect health gains. How is Acetate doing that? And what are some of the lessons you've learned that might be applicable for other advocacy campaigns?
Hello, everyone. Good morning, good afternoon, good evening, depending on where you are out there in the world. It's a pleasure to be here to have this discussion. Well, I'll start with the bad news. Well, Brazil, as you probably heard through the news, is in a very challenging situation. I mean, both politically or in terms of like the management of the COVID-19 pandemic, the situation is really bad. So I think we are one of the epicenters of the COVID pandemic. But having said that, more than ever, we can see and feel the importance of having like civil society organizations doing advocacy, and also in coordination, oftentimes with the civil servants, the technical area within the government, when you have a government that it's really anti-environmentalist, anti-health, and it's really doing, I mean, it's really making the crisis even much more complicated than it should be. Just to give you a few examples, I mean, we are at the moment talking a little bit about our food security policies, which is an area that we have really improved over the last decades. Brazil got out of the hunger map from FAO, and now we are back in the hunger map. We are in the middle of a deep economic crisis. But it's not only the economic crisis, it's completely related to the public policies that have been dismantled and also all the support programs. And why I'm saying that, because when we think about global health, I mean, we are doing a lot of resilience work. I mean, while it's really hard to like promote further policies in the field, We have a strong coalitions, I mean, more than one coalition actually working in the area. And we are able to do a lot of work to maintain at least some of the policies, or to begin to prepare for like better political times, because I think resilience is as important as moving forward, because it depends so much on the outer political context. And obviously we have the coexistence of the COVID pandemic with the NCD pandemic. So we have like NCDs in Brazil, like in particularly having difficulties in getting treatment and stuff like that. On the other hand, we also have learned the importance of having a universal health system in Brazil, which we have. Brazil, it's a country with like 200 million people inhabitants. So we have like this ups and downs and lots of things happening in order to maintain what we have, right? In the area of food security, we have like over half of the population is food insecure at the moment. And we have like about 20 million people that are going hungry. And I think this is one of the key issues to think through our contradictions. We really need to face our contradictions, which is how can you sell yourself, which is going on right now because of the upcoming food summit at the UN in September. How can you sell an image to the world as you are the large food producer and you can't even feed your own population? I think this is a very basic contradictions. Food systems are pretty much at the center of many of the challenges that we have right now. I think the COVID pandemic has been instrumental in the sense that like the inequalities became very clear, the climate crisis became much more clear, as well as the biodiversity collapse. So we can see that we have like systemic and structural issues that we need to face them. So just to conclude, we have more than ever the opportunity to put the health at the center of the discussions, which is exactly what we are doing in Brazil in terms of like two things that we are doing like on an everyday basis in our advocacy efforts. One is to have dialogues with these other movements outside from health and make the connections with health, as for example, the environmental movement and the social justice movement, because of this like increased inequalities. So this is one of the key elements in terms of like to maintain the force and the energy of civil society in difficult and challenging times. And we definitely need to use this as an opportunity. And I think this is a global challenge to use this, what's happening now, as an opportunity to build back better, not only better, but also fair. And we need to restructure our like health systems and our food systems. And we really need to think through like the externalities of, particularly in the field of non-communicable diseases, that are a number of externalities that are not paid for. So to finalize, another issue that we are working on, it's in the discussions around fiscal reform. We are really putting the issue of like taxation of harmful products in the center of the agenda, also as a way of like beginning to touch in some of the structural challenges that we have for the externalities that are not paid, for the impact of those products, both on people's health and on the planet's health. I think that's it in my 5 minutes. Thank you very much.
Wow. Thank you, Paula. That was really thought-provoking, and again, triggering more questions that I have for you and for the panel. Nalin, in the face of the devastating wave of COVID-19 in India, I understand that you and your colleagues are still continuing to push to advocate for safer roads. And why is it important to focus on road safety as a public health issue? I think this is a good segue from Paula's comments. And what are some of the lessons that you've learned that might be applicable for other advocacy campaigns as well?
Thank you, Claire, for inviting me. And I'm happy to share some thoughts on behalf of our partners, Global Road Safety Partnership, and host of road safety organizations and academic institutions from India who have a wonderful coalition. So basically, I'll be representing some of the work that they have carried out collectively and individually in India. So starting with the road safety, as you know, WHO has stated that we lose about 1.3 million people annually in the world to road crash injuries. And I think more than 20 million people get injured. And if you see, this road crash deaths are the leading cause among children and young adults from the age group of 5 to 29. And when you have some road crash injury, it leads to a very long-term, sometimes hospitalization, disability, medical care, and a whole lot of issues. So it's really, it's been now acknowledged as an important public health issue, which requires urgent intervention. Just to share with you a number from India, we unfortunately we lose about 150,000 people every year in road crash deaths every year, and about 500,000 people get injured. So if you look at the last 7-year data, we have lost about 1 million people in road crash deaths. 1 million people in road crash deaths in India alone in last 7 years. And this is completely preventable. The evidence and experiences from around the world, many countries, especially in Europe, Australia, it shows that a good road safety policy backed with a strong enforcement and public awareness and whole lot of other interventions would actually help prevent or reduce the road crash deaths and injury significantly. So this is why it's important. So we are focusing a lot of work related to policy intervention and support. Talking about our work during the pandemic time, I share thoughts with our colleague panelists from Brazil. India is also going through a second wave of deadly coronavirus, where we are recording a very high number of daily positive cases and deaths. But that's, I think, the whole lot of government and system is working towards addressing that. But in spite of having lockdowns related to COVID, we are still seeing a lot of people getting injured and getting, that dying on the road. There are several things that we have been trying to do during the pandemic challenge, lockdowns and restrictions that we have. We have mostly used digital advocacy as an important tool and area to reach out to the policymakers and provide technical support on legislation and rule making. We also had one interesting experience to share. Last year when we had a COVID lockdown, national lockdown, we see a very unprecedented movement of migrant workers from one city or state to another. And most of them, they started traveling on foot for 1,000 kilometers or by bus. And that really, we realized that it can cause a very big number of road crash injuries and challenge. So we thought that it needs to be taken into consideration, and we try to reach out to the government along with our partners to ensure that the safe mobility of migrant workers, and they were in millions. I'm sure most of you would remember stories from India or press reports from India last year when India had just announced a national lockdown. We saw a huge number of people, walking on road or taking overcrowded buses and all. So we reached out to the government, put together a set of recommendations for the government, issued a joint press statement, and reached out to all the important decision makers and policy makers to ensure that road safety provisions are included in all the government guidelines and SOPs related to the movement of people during the COVID time. And I'm very happy to share that some of it were included by the federal government in the directions to the state and various implementing agencies in the country. And we could help prevent to a little bit, to some extent, what could have been a catastrophe, or added problem, what we were already dealing with the COVID issues. So that was something very useful. And COVID has also made us realize that, every adversity brings some opportunity. So we are trying to use this opportunity to reach out to more decision makers and political leadership to make them understand the concerns and the challenges of road crash injuries, and make them understand that these are completely preventable. We don't need any new intervention or vaccines for this. We have the solution for this. So it's just that we need to act upon it. So I would stop here for the time being, and would be happy to add something later as we go along. Thank you.
Thank you so much, Nalan, and thank you, Paula, very much. I appreciate it. I want to just remind everyone who's watching that we'd really love to hear about your experiences and your work and what's working and what's not. So please use the chat to share those experiences, and also use the Q&A to pose any questions to the panelists. So I'm now going to turn to Russell Rensberg and Vandana Shah to talk about their experiences in focusing on health system strengthening and achieving health equity. Hailing from South Africa, Russell Rensberg joined the Rural Health Advocacy Project in 2017 and took up the position of director in January 2019. Russell is an expert in health systems and policy and was commissioner of the Lancet High-Level Commission on Quality Healthcare. He also manages RAP's Rural Proofing Program, which advocates for the equitable allocation of resources for rural healthcare delivery. And next we have Vandana Shah, who directs South Asia programs for the Campaign for Tobacco-Free Kids, which is the leading international advocacy organization reducing tobacco use around the world, and also houses the Global Health Advocacy Incubator. The issues that Vandana works on, in addition to tobacco control, is drowning prevention, healthy food policy, and cardiovascular health. Vandana works closely with multiple stakeholders, including government, media, and civil society, to formulate and implement political and media advocacy strategies to affect policy change at the national and subnational level. So thank you for joining us both. Russell, can you talk about what RAP is doing to strengthen the health systems and how that is helping to achieve health equity? And as I've asked the other speakers as well, can you just share some lessons you learned from your work in South Africa that might be useful for other advocates?
Yeah, RAP is, RAP is more like a policy unit. So we've got 4 broad priorities that essentially look at health, different components of health systems. So that's things like health financing, health policy, human resources for health, because without healthcare workers, there's no health system. And lastly, just on broader community engagement. And we work in an insider-outsider kind of mechanism where on the outside, we act as the activist think tank for frontline service organizations like the Treatment Action Campaign and others, where we leverage our experience in policy with their experience of frontline activism. And then we also then work closely with policymakers, right, in terms of understanding how to adapt and adjust policies to the rural context. So we're not your usual civil society organization, but we're broadly informed by principles of social justice, particularly in relation to South Africa's right or constitutionally guaranteed right to access healthcare services, including emergency medical services. When it comes to COVID, I think COVID for us was one of those things where, first, it was a big external shock. There was no ways that as a system we could have planned for a massive pandemic to really close down our economy for over a year. And in South Africa, it's particularly pertinent because 80% of healthcare services is publicly funded. And that public funding is ultimately what determines whether people get access to life-saving care or not. So when as we're beginning to unpack what comes next and how we want to work with our partners in driving forward a more intentional agenda post-COVID, is to really just borrow on the lessons. And I think what COVID has taught us is that there is no economy without healthcare. I think we were left hopelessly unprepared for this level of health crisis and the broader economic impacts. And I think in one sense that creates an opportunity for governments and partners to invest more in health. But we also have to invest in the right things. And I think that's where the importance is of dialogue, working with both within your sector and intersectorally to ensure that we are all advocating for similar things working towards a realizable agenda. And I think to guide that, we sort of use this 3+2 broad framework, which is looking at the fluidity of systems like health system components, like financing, like human resources for health. And what now, more importantly than ever, is health management information systems. And in terms of the latter, I think we're working with our partners in Kasi Sonke Siapile, which is a Bloomberg or a global health advocacy incubator funded program, to start working with health activists on advocating more intentionally, not just for health system deficits, but also the broader determinants of health. And in South Africa, food is an important part of that. So through the Kasi Sonke Siapile, over the next while, we intend to be a lot more intentional with our advocacy, making sure that we invest in the kind of health systems that benefit those most at risk. That's mostly primary healthcare. Working with our partners as frontline activists, I think we want to sort of put a spotlight on the broader determinants to health, particularly the right to food, and within that, creating a food environment that's well regulated to ensure that those most at risk are able to make conscious choices that doesn't negatively impact on their broader health seeking. Thank you. Over.
Thank you, Russell. So Vandana, I just lost my place, I apologize. So Vandana, what impact can advocacy have in achieving health equity? And I'm curious to hear about the work that your work in South Asia, how that has played out and what lessons can be shared with other advocates.
Thank you, Claire. So, there's already inherently very deep inequities, in health in South Asia. And, I would say there's sort of three core factors. There's geography, there's socioeconomic factors, and there's gender. And we found that all of these were sort of exacerbated, during COVID and then the resulting lockdown. And, we're now in lockdown part 2 in all of the countries that I work in. So I want to share sort of three very different examples from the work that we're doing where we sort of, really focused on the health equity factor as a part of our advocacy. Because in some ways, the people who are sort of adversely impacted, the most vulnerable people and who have the least healthcare rights, they also had the least opportunity to advocate for themselves or to seek healthcare as a result of COVID and the lockdown. So the first example I want to share actually is on drowning prevention in Bangladesh. And so this is a really successful pilot project where children under 5 are placed in daycares in Bangladesh. And this project has shown an 88% decline in child drowning, because drowning is the leading cause of death for children under 5 in Bangladesh. And as a result of COVID and the lockdown, these daycares have, of course, been closed. Part of our advocacy is focused on getting the government to adopt this pilot and to extend it for the whole country. And we've been going through this process with the government of Bangladesh over the last 12 months. And so what we did was that the actual recipients of these programs, the mothers, the children, we actually traveled out, during once the lockdown lifted in 2020. And we actually began to sort of getting their video testimonials. We started doing, sort of radio, and some PSAs. We actually have a national consultation with the government and the Ministry of Women and Child Affairs, really bringing out the testimonials of how these programs are so critical. They're in the most economically disadvantaged rural areas. And I think sort of one of the main lessons out of this program is really making sure that as you're sort of advocating for these people in order to have access to these community-based services, you really bring out their stories, their experiences. Shifting gears to a program you actually just heard about from Dr. Kaur in India, this was another really interesting example where we were working with the government of Punjab and strengthening primary health care. And once again, it's the people who are sort of farthest from these primary healthcare centers who have no access to physicians. And obviously, all of these gaps got heightened because of the situation in COVID. And I think and even though Punjab and the rest of India had health telemedicine infrastructure in place, but this was not being utilized. So you had people locked at their homes and with no ability to access physicians or specialists. So one of the ways we really sort of focused and sort of supporting the government and advocating for actually activating the telemedicine center was really based on the principle of health equity, to be able to reach the lowest common denominator. And I want to say that we've had over 30,000 telemedicine consultations going to just from a few hundred prior to the lockdown. And in some ways, even though telemedicine sounds like such a great, high tech, high technology thing, it's turning out to be a great sort of equalizer, providing access to vulnerable populations, in these times. The third area which I want to highlight, and which I think, both Russell and Paula have sort of talked about in their remarks, is sort of really working on strengthening food systems. So in some ways, as we're locked in our homes, and I think food is both a comfort, but it's also a danger, as we are all trying to maintain a good, strong immune system, strong cardiovascular health. Eating healthy is so very critical to, sort of being able to fight off the infection. So one of the campaigns that we were working on in India and Bangladesh is the complete elimination of trans fat policies. So once again, we actually really sort of highlighted how vulnerable populations, low income populations, especially their kids, were relying on packaged foods and on pre-prepared foods. And we really sort of highlighted the need to completely eliminate trans fat from the food. And I want to say, and I want to end with the success story, that really using sort of the vulnerable populations argument, the health equity argument, in India, we did manage to have a big success in January this year, where we've managed to eliminate sort of trans fat completely from the both the oils, fats, and foods. So in closing, I'd just like to share, Claire, that in sort of each of the policies that we advocate from, which range from a variety of things, I think it's very important to bring out the impact of that policy on the most vulnerable populations, that are least likely to be able to talk and sort of share their cause. And I think that really sort of helps in sort of being a great equalizer. So thank you, Claire, and back to you.
Thank you, Vandana. I think that was great to provide all those different examples as well. And I always like to end on a success story. So now I'm going to turn to my colleagues, my incubator colleagues, Huen Duen and Dr. Emmanuel Hassan. So Huen is the Vietnam country director for the drowning prevention program at the Global Health Advocacy Incubator. She coordinates with policymakers, government, and civil society organizations to support the planning, launch, and implementation of community-based interventions, particularly around survival, swimming, and daycare. Prior to joining the incubator, she served as a program manager and researcher at the Vietnamese Ministry of Health, focusing on tobacco control, road safety, and avian influenza control. Next, Dr. Emmanuel Hassan is the Nigeria Coordinator for Preventing Epidemics program at the Global Health Advocacy Incubator. He works with various stakeholders to advocate for changes in budget and other policies related to government, to preventing epidemics. He has prior experience working with the corporate, private sector, government, and international development partners. He holds a Master's of Science degree in Organizational Psychology, an MBA, and PhD in Psychometrics. He is a Senior Executive Fellow at the Harvard University Kennedy School, an IP3 Certified Public-Private Partnership Specialist, and a Fellow of the Institute of Corporate Administration in Nigeria. So thank you for joining us. Huen, we'll start with you. How does national and local advocacy for health budgets impact everything we've discussed today? So, how does doing something at a national level help impact something on the subnational level? And what lessons do your experience hold for other advocates?
Thank you, Claire, for your great question. And it's my honor to participate in the virtual event today to share the very specific story from Vietnam. And as you may know that in Vietnam, nearly 2,000 children die from drowning every year. And this silent killer is the country's leading cause of death among children under 15 years old. And since early of 2018, when the Bloomberg Philanthropy announced this 5-year program, we have established a partnership that could be very critical to ensuring the success and the financing sustainability of the program through our partnership with the leading ministry, and that is the Ministry of Labor, Invalid and Social Affairs, and the Global Health Advocacy Incubator and the World Health Organization in Vietnam are the key implementing partner, working very closely with the ministry to prevent children from drowning. And this is being done closely by helping the government to test, scale, and sustain the evidence-based intervention survival stream for the children. And our role is both in the program design and implementation, as well as supporting the messages for advocacy efforts. And so, as the early stage of the planning and the implementation phase, we aim to put in place the human resources, the government budgets, and the infrastructure so that the program could be continued without further international funding when the program ends. And by the end of the first 5 years, we hope that the intervention could be reached by training for at least 40,000 children on life-saving survival swim scheme that could be covered at least 20% of the national drowning burden for the children under 15s. So let me mention about the key success so far over the last 3 years. The first highlight could be seen in the local co-funding for the program intervention, already increased 4 times, amount for nearly $1 million per year. And the local financing for the survival stream is 10 times higher than that before the program intervention. And with the no budget advocacy work happened. And given the very initial success of the program in reducing the drowning case, we implemented in the 8 provinces who have faced with the highest burden of drowning in the nation. And the program has been successfully to cover increasing from 8 provinces to 12 provinces, and with a very geographic reason represented for the different regions of the country. And over the last time, we provide training for nearly 14,000 children, already successfully training on survival swim, and more than 22,000 children already learn the water safety education in the school settings. And we also provide the training for the master trainer on survival swim. And we also have a co-funding to build up more than 60 pools and already available with the local funding, and the 13 newly portable swimming pools equipped by the program fund. And I want to highlight some of the very successful and the 4 elements for the program lesson to share. The first, but really most important, that is the long-term version. The first is how to integrate our wound into the child rights program in the country, and how to advocate to include our target into the national policy and the national budgets. That's really important. And now we're recently working to advocate to adding the drowning prevention to the 10-year action plan on child injury prevention of the nation. So based on that, when we successfully to pass this very important action plan in late of July this year, we will created the legal-based foundation for the government investment and their priority for the action. And the second is the community ownership. We understand that no one size can fit for all, and the intervention could be tailored to the local circumstances, the demand, and the available resources. And these factors are respect and more value when we interacted with the integration in different geographic region, the remote area, the people living in the ethnic group, and with the very limited resources. And we are working to ensure that the community could be working closely and keep the program moving, even we don't have a further report when the program phase out. And the third element I want to share, that is the united. The government lead the program because we involved in the national policy, but the other support from the civil society, the parent association, and also value and practice. And the diverse partnership is really important to bring the program to the grassroots level, to the bottom-up approach, and beneficial for the owner, the people, and the children. And in the future, we will also call for the joint hand of the non-profit enterprises and INGO and the child rights group in the country, and we've been working with them and encourage their proactive engagement and joint action for the program. And the last but really important, that is the sustainability and the political commitment and the local ownership as a key success for the program. And the public financing for intervention has been increased year by year, and during 3 years intervention, the program invested at least $30 per child to let them learn from survival swim and the water safety education. And in comparison with the pandemic COVID-19, I think that it's worth to pay off this little amount of money to reduce the risk, nearly 90% risk of child drowning among the children. It's just like some kind of vaccination to have children protected from drowning. And so that is really important to sustain the program. So in conclusion, I want to highlight that working with a very specific political situation and the system in Vietnam should be have the think about the sustainability from the outset of the program. It's not only to start off the conservation, how to make the program begin, but how to make it end. And then that is very critical piece of, pieces of our work currently in the Vietnam. So thank you, and it's over to you, Claire.
Thank you, Huen. Now, Emmanuel, as our last speaker, what were the essential elements of success in mobilizing resources in Nigeria? And also, what are the key take-home messages you would give to other advocates who are also trying to do budget advocacy?
Thank you very much, Claire. It's such an honor to be part of this panel. Let me just quickly say that it's COVID-19 has actually shown us the importance of improving and investing in health security, since evidence shows that the return of the investments is really, really amazing. Political will is needed to prioritize investments in preparedness. It's just that the challenge is that politicians and the public usually take these issues seriously when there's a pandemic, when there's an outbreak. And then in between outbreaks, you have people just going to sleep, so to speak. The commitment wanes considerably. But we have discovered in Nigeria that civil society and indeed members of the legislature, that's lawmakers, and key actors in the executive branch play key roles in advocacy for increased investments in epidemic preparedness. My country, Nigeria, has taken important steps to improve epidemic preparedness in recent years. We assessed capacity to prevent, detect, and rapidly respond to public health threats, developed a national action plan to fill preparedness gaps, and designated a federal agency, the Nigeria Center for Disease Control, to oversee preparedness and response. Now, In spite of the growing public and political awareness of the need for preparedness, efforts were underfunded, perpetuating a reliance on support from international partners such as the World Bank, the US CDC, and domestic donors such as the United Bank for Africa and wealthy philanthropists like Aliko Dangote. The Global Health Advocacy Incubator has been supporting civil society actors in Nigeria since 2018 to advocate for domestic investments in preparedness. And this big success story is that NCDC's federal appropriations more than doubled between fiscal 2019, when they had 1.4 billion naira allocated or budgeted to them, and fiscal 2021 with 1.4, with almost 3 billion naira. Secondly, the country's second most populous state, Kano, created a 300 million naira budget line for epidemic preparedness and response. Just to quickly say, before I look at the key lessons and perhaps proffer a few suggestions as to what to do to ensure success, it's important to say that Nigerian advocates have succeeded in framing epidemic preparedness as a public health priority through a multifaceted campaign supported by GHAI. We compiled research on the impact of disease outbreaks and the cost benefit of investing in epidemic preparedness. We organized policy discussions, held breakfast meetings, field trips, roundtable discussions, webinars, to educate administrative and legislative leaders and their staff and generate their commitment to improving preparedness. We engaged in advocacy activities early in the budget cycle by conducting political mapping immediately after the National Assembly was inaugurated, and cultivated epidemic preparedness champions on relevant committees in the parliament. We also worked with journalists and social media influencers to increase the quantity and quality of media coverage through media roundtables, webinars, calls, site visits, and other activities that keep the issue of preparedness high in the public and political agenda.
It seems Emmanuel has frozen. Emmanuel, I'm not sure if you can hear us. Okay, well, I know we're working on limited time. So I am going to actually move us into the Q&A session. And I'm so sorry that we've lost Emmanuel. Can I ask all of our panelists to turn their videos on, please? We have a few questions, some specific and some a little broader. So I was going to start. I noticed there was a question around using a human rights-based approach to this work. And I would be curious to hear from the panelists. So the question is, have you used a human rights approach or mechanisms to address health gaps and health equity? And what were the results and what were some of the challenges applied to that? I know, Paula, you responded to that in the Q&A, but I wanted to give some of the other panelists as well. And Paula, obviously hear more from you about using it more of a human rights approach. Does anyone want to start?
So if I could just chime in a little bit on sort of along the lines of what Paula said, unlike South America, human rights approach is not sort of as robustly recognized, but we have begun to especially use it for the right to, healthy food. And I think food systems, because, we obviously, our country is really prone to hunger, and there is sort of, an embedded, right to food. And we're now trying to change it as we're working on, cardiovascular health, on trans fat as a right to healthy food. Even in our front of package labeling, we're looking at possibly exploring that right. Also, the one more than sort of human rights, there's sort of a very strong belief and sort of acceptance of the right to life. So I think even that, for say drowning prevention or even tobacco control, has been used. So but it's nowhere as robust as sort of the work that Paula is able to do in her context, in terms of a human rights approach.
Our work in South Africa is, again, very rights-based, and I think obviously we have a Bill of Rights. We guarantee everybody access to healthcare. Well,
my apologies, Claire, and everyone.
Thanks. I'm so glad that you're able to join us again.
Can I continue?
Russell, do you want to finish that thought?
Yeah, so I think rights-based approaches are always at the baseline when we're trying to address inequality or equity of access. But I think the challenge that we often find with rights-based approaches, while strong proponents for it, is that rights are afforded to everyone, including people who have an over-enjoyment of the right to health. Sadly, health is like one of those businesses where there's scarcity of capacity, right? And there's even inequities within the system between like tertiary levels of care, primary levels of care, and so forth. So the rights-based approaches can work for you and against you. And I know that even in Brazil, there are some instances where the elites have used the right to health, as a means to ensure that they have access to certain things publicly, which potentially is to the detriment of the broader population. And I think what COVID is teaching us as we move forward in starting to think about these rights-based approaches is, how do we think about the enjoyment of rights? Do we have to work on some kind of rights prioritization, where the people with the least access are the people that should be the subject of our advocacy, so that access expands for marginal groups like rural populations in particular, and gets maintained for people who have an over-enjoyment of access to care. And I think the same thing applies again to other life-saving treatments, like for instance, cancer treatments, which are very dependent on early diagnosis, right? But a lot of, like in our country in particular, a lot of the capacity is trapped in the private sector where people have an ability to pay. And in the public sector, because poorer people, health utilization or health literacy follows the social gradient. So invariably, poorer people are less aware of the kind of health seeking they need in order to extend life. So I think what COVID has really taught us is that we really need to think a little bit more about how we advocate rights-based approaches, and how intentional we are to ensure that at the end of the day, the vehicle also delivers us to the destination of broader equity and equality. Because unfortunately, rights are afforded to everyone, and they can't be taken away. And we haven't really had a conversation of the rights of the rich, or how we can, I don't want to sound too radical, but how can we limit claims on the system with an intention to ensure that more people have access. Thank you. Over.
Thanks, Russell. I want to give Dr. Kaur a quick chance to respond. I know you were going to, and then Paula, I want to give you a chance, and then I'm gonna we'll move on to a next question.
What I wanted to say was that by strengthening our rural healthcare, we have sort of responded to right to health of rural people, because mostly the hospitals and all the healthcare is built around major cities where, even the government sector has bigger hospitals, colleges, medical colleges, and healthcare facilities in the cities. But for rural people, because of our units in the villages itself, I want to point out here that we have been able to identify pregnant COVID positive women, which has been a very big step. Even in our country, I think we are the only state which has focused on pregnant COVID positive women. Our community health officers have identified them, and they have been provided with medicines, and we are doing teleconsultation with them daily to prevent any, because we were having COVID positive mothers dying, were reported like last month. And when the reports came in, we started focusing on COVID positive pregnancies, and our people are focusing on the high risk groups in the villages. And also we are going big way into vaccination in rural areas because of our centers in the rural areas. Otherwise, all these people would have been left out. Thanks.
Thank you, Dr. Kaur. Paula?
Yeah, just to add to this, I think it's a fascinating conversation, and from very briefly and oversimplifying it because of, for the sake of time, in Brazil, I mean, social movements and left wings and so on, everybody supports that, right? And reasonable people. But I mean, in a situation with a right wing government, it's not how you get an entrance, it's not how you get an opportunity to advocate. You have to use like economic arguments, and actually this is what resonates also with like more conservative and traditional medical societies. You have to use the economic, I mean, what it causes in the economy, and this is much more powerful, particularly talking about the externalities, which was also the question mentioned there. It has a cost for society that you need to consider, because at the moment we start talking about human rights in Brazil right now, it's mixed. I mean, it's interpreted something to protect like bad people and marginals, and it's like, and this is the situation right now. So I think it very much depends on the political landscape.
Thanks, Paula. Thanks, Dr. Kaur. I apologize to my panelists because we don't have a ton of time left. And I do want to actually give Emmanuel a chance just to say some last, to share a few of those lessons that he got cut off from sharing. So I know that some of our other panelists would like to comment on this as well.
My apologies, there was a glitch here. Sorry about that. So just a few important lessons, just a few of them. One is that sustained advocacy for epidemic preparedness is essential to ensuring long-term investments, which are made beyond immediate crisis. Secondly, leadership by local civil society is critical to developing effective coalitions and successful advocacy campaigns. It's also important to know that advocates should engage high-level political decision makers, such as ministers of health, budget and finance ministers, as early as possible in any campaign. Political decision makers are more likely to support funding proposals backed by evidence, as one or two other speakers have alluded to, and can be effective policy champions among government peers, just as we have in Nigeria. Sustained media coverage can help to frame epidemic preparedness as a national priority. And finally, journalism trainings and webinars are effective tools to catalyze media coverage and generate support for epidemic preparedness funding. Thank you so very much.
Thank you, Emmanuel. I know Nalan was signaling he had one last comment he wanted to make before we close out. So I hope you could do it in like 90 seconds.
Yeah, thanks, Claire. Yeah, so on the question of human rights, I would mention, as Vandana said, in India, we have in the Constitution, several rights given to citizens. They are called fundamental rights. And there's a fundamental right to equity under Article 14, and there's a right to life under Article 21. So some of our partners are exploring the possibility, because a lot of people are dying. That's one aspect. And they have a right to life. And second, there is also a right to equity matter, because you see, road safety also is determined a lot on the infrastructure that we build and the alternate system we create for mobility for people, whether it's public transport, bicycle infrastructure, pedestrian infrastructure. And we feel that there is a scope for raising this issue of right to equity to address and to take up into the government. But we are looking at the all those possibilities so that the case stands in the court of law. And as soon as the COVID things eases, some of our partners are thinking of invoking those clauses, articles given in the Constitution to ensure that we can reduce the high number of fatality. So just wanted to add these 2 points. Thank you.
No, thank you. I'm glad we had time to hear those final comments. And again, I'm glad Emmanuel was able to join us again after that glitch. So we have 1 minute left, and I want to thank our fantastic speakers, all of you. We really appreciate you joining us today, and Adriana, our interpreter extraordinaire, and a huge thank you to all of you for joining us today. We'll send a follow-up email that will include a recording in English and Spanish. And in the meantime, please follow us on Twitter using the handle on the screen. And I hope that all of you enjoy the rest of your day or evening. Thank you very much.
Thank you.